about the cervical cytology and HPV testing and their roles in cervical cancer screening. Cervical cytology and HPV testing are two very important methods or tools played a very important role in past many decades in cervical cancer screening, especially cervical cytology. They are mutually benefit. And so what I'm gonna do in next hour, gonna be start with HPV virus, HPV infection, and HPV testing. That's what I started with my fellows and the resident, because I think for cytopathologists practice in modern era, we're not only focused on cytomorphology. You must have a profound foundation for HPV infection and HPV testing. So then my second half are going to be briefly review cytomorphologic features of dysplasia in squamous and glandular lesions. So as we all know, cervical cancer is the second most common cause of cancer-related death among women, especially those younger women less than 50-year-old worldwide. Currently, vast majority, 85% of cervical cancer occurs in those low-resource areas or countries without a regular nationwide screening program. This map just gave us a bird view of the incidence of cervical cancer. You can see those purple, red, those clusters, mainly in Africa, South Africa, and Asian countries. I don't think the China map is correct because I have been doing 15 years of cervical cancer screening in China and in some areas in North America. So HPV in US, probably same as in Europe, is the most common STD. More than 90% of men and 80% of sexually active women will be infected with HPV in their lifetime. Currently, about a quarter to a third of women already infected, which count roughly 80 million women and men, and with 40 million new infections every year. There are about more than 150 HPV types. The HPV types relate to human disease in skin and mucosal cluster around those 70 types. Most commonly 40 types of HPV involved in anogenital areas. So based on their malignant potential, the potential to cause a dysplasia, we roughly classify them into low risk with prototype HPV 6-11 and high risk with HPV 16-18 as prototypes. This is phylogenetic or taxonomic map about those most common HPV types linked with human disease in the skin and the mucosal. You can see this red, this tree, especially HPV 16-18, HPV 6-11. These are the most common HPV types associated with cervical, anal, and vulvar squamous and glandular dysplasia. If you look at the population, there's some similarity and discrepancy, if you will, between among different regions, countries. In Australia, North America, Europe, you have, well, HPV 16-18 are common, the most frequent one, regardless anywhere you go globally. However, if you look at the rest of those 7, 8 in the sequence, the most frequency, they're different slightly. For example, China and Asia, you got 58, 52, 45. Those are top 5 after 16, 18, but in US, 31, 33, and 45 are most common, which shares some similarity with South and Central America. If you look at the HPV infection modality, they're slightly different. This lighter blue one represents the US. You can see the most frequent infection seen in those younger women, usually less than 25-year-old, sexually most active and got the most prevalent HPV infection. However, if you look at the China population, which I participate in the different areas, metropolitan or rural area, although the frequency are different, but the modality are quite similar. Similarly, like US, you have in the youngster, you have a high peak start at early, but you got a second peak between 40 to 45-year-old in China, maybe another Asian countries, which is really interesting, probably reflecting cultural and the socioeconomic habit, if you will. So HPV infection, we look at it from 2 different angles. Clinically, we divide the stage into transient infection and persistent infection. This is kind of arbitrary. In most of the consensus in literature, we define 2 years continuous HPV infection. Less than 2 years, we call transient, and more than 2 years, we call persistent. The high risk are really those population of women with persistent infection. These tend to occur in women with multiple sexual partners, older women, or women with immunocompromised conditions. This is schematic draw 20 years ago, but I think it's still very good to summarize the transient persistent HPV infection linked with squamous dysplasia. If you look at it from HPV infection starting to the invasive carcinoma, it takes a quite length period of time, roughly 8 to 10 years, which provide great window opportunity for us to do the screening and identify early lesions and early intervention clinically. That's why in the Western countries with regular cervical cancer screening program, even HPV infection rate is much higher. For example, in US, 1/3 of women had HPV infection, but in China, on average, in the rural area, somewhere 5 to 7%, but in the city metropolitan area, somewhere 10 to 15%. On average in China is 10% HPV infection rate. However, the cervical cancer load or incidence in China is probably 5 times higher than US, which tell us the cervical cancer screening early detection is so important. The age population have a quite an important impact linked with HPV infection. 80% of HPV infection occurred in women younger than 30-year-old, and majority of younger women have the HPV infection are transient. So 90%, that's also study data, even they have early disease, meaning ascus or LSIL, they will spontaneous regress without any clinical intervene or treatment. So the persistent HPV infection increase along with age, but the spontaneous regression rate decrease with older woman. Most of HSIL, CN2 and 3 seen those women 30, 35-year-old or older. So this is a prevalence. You can see most of infection in the younger population cluster of this. But if you look at the persistent HPV infection, most are in the older women. So in this kind of 10-year roughly period of time, there's an individual difference between mainly depend on their personal immunity status. But on average, you have a lengthy period of time from transient infection to persistent, and a still very small percentage of those women with persistent infection, you got a squamous dysplasia from low grade to high grade to invasive carcinoma. But if you look at HPV infection from biological perspective, we divide it into episomal stage and integrated stage. Those are transient early HPV infection. They are mainly exist as episomal. So they exist as a circular episomal DNA separated from the host cell nucleus. So they take advantage of a host cytoplasmic protein synthesis machinery to reproduce themselves. So it's very contagious in the episomal stage. And when the persistent infection in these women that provide opportunity for HPV integrated into host genome, that's the hallmark for malignant transformation. All the H cells have integrated HPV status. This is an HPV genome. I will not bore you for that, but what I want to emphasize are two very important viral proteins we call viral oncoprotein E6, E7. These two proteins, when integrated, highly expressed. What they do, this HPV virus, very smart. They pick up two very important tumor suppressor proteins, P53, PRB. It's like, I'm thinking like a police station. They first knock down the police station before they cause this genomic instability and the mutations cause malignant transformation. So this is just to give you a schematic view. This circular DNA represent episomal stage. This is a linear DNA integrated in the host genome, and the circular episomal stage you tend to see in early infection and low-grade disease like condyloma and LSIL. But HSIL, AIS, and the carcinoma, you do have this integrated HPV, which drive the malignant transformation. So this is the summary by Dr. Loy from NIH 20 years ago. This is a great understanding. When I teach my resident, this is a map I want them to understand, because it's really in the bottom summarize the molecular carcinogenesis and the molecular alterations during the HPV infection from transient to integrated, to episomal to integrated stage. And in the transient, you got this LSIL, CN1, which produce a lot of virus. So LSIL, CN1, these women have much more contagious status clinically than those women with high-grade dysplasia, which they do not have a circular variants. They integrated, therefore the contagiousness dropped, but the malignant transformation significant increase. So CN2 and CN3 is really how much of these basal, parabasal cells, replace the full thickness. Cytologically, we use NC ratio. We'll talk about that in cytology part. So among all the HPV types, we have to single out HPV 16, 18. These are two different, they're outliers, different birds. They count 50% of all female genital HPV infection. HPV 16, 18 count for 2 to 3 times more likely be persistent and the highest potential in malignant transformation to high-grade lesion and invasive carcinoma. If you look at it from disease point of view, 95% of HSIL will have high-risk HPV infection. Among those, 70% will have HPV 16 and 18. So HPV testing, especially genotype testing for HPV 16 and 18, in past 10 years, a lot of data, already demonstrated. It's very important to single out these two HPV types. If you look at different regions, areas of HPV infection associated with high-grade disease, you can see HPV 16 and 18 count at least 50% to 70% in the different areas, and which are really the one we're going to focus on when we do HPV testing. If you look at this CN3 in 10-year cumulative incidence rate, you can see HPV 16 way significant, higher than 18, higher than other HPV types, and higher probably than low risk. Here they call it HPV negative. To me, it's probably low risk because the HPV testing not include low risk types. So HPV 16 in the different regions, Asia, Europe, North America, South America, the #1 HPV types linked with squamous cell carcinoma in the cervix, vulva, and anus. But HPV 18, on the other hand, is the most common infection linked with adenocarcinoma, adenosquamous, and neuroendocrine carcinoma, including small cell undifferentiated carcinoma. From cervical dysplasia point of view, if you look at the condyloma, 100% of those infected with low-risk type HPV. But for LSIL CN1, 85% caused by high-risk HPV, and you got 15% caused by low-risk type of HPV. But HSIL and squamous cell carcinoma, 95% of those have integrated high-risk type HPV. During this HPV infection and tumorigenesis process in early stage, we call it infected, but not really malignant yet. So those early CN1, we call mild dysplasia. Vast majority of those can be regressed back, even not treated, especially in younger women. That's why as a CCP for LSIL in women less than 30-year-old, we're not to do any aggressive treatment, just follow up with PAP. That's linked with this kind of epidemiology data. Even CN2 in younger women, their immunity is high, about 1/3 they can regress, back to normal. So this is the kind of bird view to see what do we have the situation. You have a lot of HPV infection, but if you put a low-grade, high-grade squamous carcinoma together, you about have 1 out of 40 will have a dysplasia to carcinoma. And in each stage, especially early stage, they can be regressed. So these are very important knowledge, to know when we review our cytology. So this is a picture really shows the important role of cervical cytology. Cervical cytology used for clinical testing start at Harvard MGH, the Massachusetts General Hospital in 1950s. So gradually in US and Europe start use cervical cytology, and HPV testing started use 2005. So in these 5 decades and pretty much just cervical cytology, and that's one methodology to get a cervical cancer really significantly reduced. I really feel Pap Nicolau need receive the Nobel Prize award, because no other single methodology like cervical cytology plays so much important role. Of course, we work with clinicians, colposcopy play very important role along with cervical cytology. So in this cervical cancer screening paradigm, and we have cervical cytology now with HPV testing, one with great sensitivity and another with great specificity. It's very robust. And you have a histology. Now we have a P16 immunohistochemistry to separate CN1 from CN2 and 3. So I think pathology, cytopathology did great in past few decades. The weakest link is colposcopy. I participated in 15 years, the clinical screening to the rural area. Personally, I've seen probably more than 50,000 colposcopy. And I'm telling you, that's not rocket science. It's oftentimes they miss the biopsy, miss the lesion. I have a paper published in 2008 in G1 Oncology, talk about cytology, histology, and colposcopy, how much they missed. So cytology and HPV testing. If you look at the sensitivity and the specificity, for HPV testing is highest, regardless of how much you drop your diagnostic threshold for ascus, you never cytology surpass the sensitivity of HPV testing. But on the other hand, cervical cytology provide a great specificity. So these two, 95% really make it a clinically, very high sensitivity and specificity. For HPV testing, it's not really important they're positive or not. It's really important it's negative or not. So negative predicted value is very, very high, especially if you have a repeat HPV testing. So if you look at the cervical cytology diagnosis category, and the HPV infection rate or positive rate are different. Even among those with cervical cytology negative, you have up to 20% those women are HPV positive. Ascus somewhere between 40 to 60% with average 50%. Ask age 75%. Then when you go to dysplasia, HPV positive rate gradually increased. So HPV testing have many roles or utility clinically. Besides the triage, abnormal cytology like ASK-H and AGC, AEC is a great tool right now, serve for quality control for cytology, especially the HPV and ASCUS, the ratio. And it's great to use cytology, histology, discrepancy, and clinically, HPV negative or positive, along with cervical cytology, will determine the lengthy screening intervals for different population of women with different risk factors. HPV 16, 18 genotyping become very, very important for those women follow LEAP procedure. Of course, in many areas already consider HPV testing serve as primary screening. I think it should have two different cervical cancer screening modality. In the developed country in US and Europe, you have a very sound cervical cytology screening program and very great community cytopathologists. But that model cannot be copy-pasted to the low resource area like China, India, and other area, which really like cytopathology pathologists and do not have a cytotechnologist. So for example, in China, you only have a 10% population HPV positive. So it's a great opportunity to do HPV screening first to identify those 10%, then you apply cytology to those 10%. So also in other countries like Australia, already used for many years HPV primary screening. I read their data was very encouraging. So I think this world should have 2 legs instead of 1 leg and 2 different models for cervical cancer screening in different areas. So talk about HPV testing used for quality control of cytology lab and for cytopathologist, diagnosis. HPV rate should be roughly somewhere between 40 to 60. Ideally, should be 50%. That's not high demanding. That means whatever we call ascus in cytology only require 50% linked with HPV infection, another 50% not. It's like a toss coin. But if your HPV positive rate among the ascus you diagnose it too low, less than 30%, you generate too much false positive cytology. On the other hand, if your rate is too high, above 70%, you're gonna worry a little bit. Maybe your threshold too high, you're gonna worry about a false negative cytology. So this is in our department. This is first half 2022, second half 2022. So you can see roughly around 45%, pretty consistent among, in the lab. That's great, very close to 50%. So this is my personal, I got, 6 months. I didn't do much because I do 40% of cytology, 60% of GYN. I got 200 cases. So here's my ascus HPV rate. Perfect at 50. I'm happy for that. Look at my ascus age. I got a 6 out of 8 HPV positive, which is 75%. So I'm happy with whatever my diagnosis criteria right now. Just, pretty satisfied, not too high, not too low. And HPV testing, like I said, used for cytology, histology, correlation. Fadi and I wrote a review on this. I would not to say too much, but in one situation, say, if you have cervical cytology called HSIL, but biopsy is negative, what a clinician gonna do? So clinician gonna call you, you're gonna answer, you said, okay, HPV testing is a 95% sensitivity, you have a 5% false negative rate. Actually in our lab, is 6.1%. So it's dependent on your lab. So, and also low sensitivity by colposcopy, they miss a lesion, right? You want to review the cytology if these are really HSIL. Then the HPV testing is really important in these women. If it's a negative, they can manage it relatively conservatively, right? So HPV negative cervical cytology called HSIL, but biopsy is negative. You can just repeat the HSIL and repeat biopsy. So if it's a positive, even biopsy is negative clinically, may consider for LEAP procedure. We have several cases like that. Usually these are older women, near or in the perimenopausal, postmenopausal period. And HPV 16-18 followed the LEAP procedure, like I mentioned. I will not go through this, but I ask my resident fellows, this is things they need know it by heart, because we're not just morphologists. We need to know the clinical, we need to know the molecular. So those are 2 things we are the bridging from basic science to to the bench side. Now I will use another 30 minutes to quickly review some cytomorphological features. LSIL, low-grade squamous intraepithelial lesion. This is the most easy part for cervical cytology because they just have such characteristic features. My first year resident, if I teach them 3 times, they can independently pick up all these lesions. The features really, they have enlarged the nuclei, low power you can pick up, 2 to 3 times bigger than intermediate cell nuclei. And not only enlarged, the nuclear enlargement, I tell my resident, I said, that's a sensitivity. But the nuclear irregularity, including membrane shape and hyperchromasia, that's specificity. So I need to pay attention to that. The difference between low-grade and high-grade dysplasia is really NC ratio. LSIL tend to be binucleated and with syncytial aggregates, especially on the surface. Holocytotic change you can see in 1/3 to half of the pap smears for LSIL diagnosis. So this is a typical LSIL cytomorphologically, low power and high power. You can see binucleation here, nuclear enlargement compared to adjacent intermediate nuclei, 2 to 3 times, nuclear membrane irregularity, and a very, very hyperchromatic. Perinuclear halo, if you're lucky, you can see it, but it's not in every single group or any single case. This is a case without halos, but this is LSIL. You can see one feature is a nuclear pleomorphism. So if you think these are grandson, these are grandpa, you have 3 generations, really tell you the size difference, very pleomorphic in LSIL. But they aggregated together, low NC ratio. This is another case. You tend to see this syncytial aggregates, especially with these orangeophilic cells, because these are surface cells. And you tend to see this surface orangeophilic aggregates in LSIL. That's because molecularly it's episomal. It's released, they release from surface and reinfect, herself or infect others. But the keratinized stuff is very less commonly seen in HSIL. So they aggregated together, I call parakeratosis, a typical parakeratosis. So to me, when I see this low power, I have 3 differentials. One is HPV-related LSIL. One is fungal infection. They tend to have this surface aggregate. Sometimes we call it a shishikaba, linked with all these cells together. And sometimes we see this in the older prolapse patient. Those are 3 very common situations we see this para-K. So the point is, whenever I see this aggregate, especially the surface one, I look at how high power to see if I see any fungal infection. HSIL, in contrast with LSIL, higher NC ratio. Usually the nuclei enlargement is not dramatic like LSIL. It's like 1.5 to 2 times the intermediate cells. They tend to be loosed. They lost the cohesiveness between the cells. So you tend to see smaller group or individual cells. At the beginning of thin prep, you call litigation cells, because thin prep, the vortex break down these cells. They tend to be very individually sneaky to bury there. If you don't look carefully, you can miss it. Again, you got an irregular nuclear membrane, coarse chromatin, hyperchromasia. These cells, if you look low power, they tend to be uniform. I call it a clonal. they do look very clonal from the same family. Like I said, you can occasionally see keratinized HSIL, but very rare. So these are the two groups, okay? And this group, very hyperchromatic, clouded group with high NC ratio, hyperchromasia. I would say this is probably CN3, and this is look like more like a CN2. And sometimes when you have this lesion, it's a challenge, especially when you have a background of LSIL. Is this part of the spectrum or is already into the HSIL? So each individually, you have to take the consideration. But if you look at this, they're very uniform, look like a clonal from similar size, less variation than LSIL. Still have quite cytoplasm, but compared to LSIL is much less. And one of the differential diagnoses for HSIL, that's almost every single case is separated if this metaplastic cells or if this HSIL. There's tremendous overlap, especially when you deal with those angry, so-called atypical squamous metaplasia. And to separate that, really need experience. But I would say the nuclear feature is really key. These are very homogeneous. If you look at these, you got a nuclear membrane irregularity, you got a coarse chromatin pattern, and hyperchromasia. And in the metaplastic, even in the very angry one, you see the prominent or conspicuous nucleoli. The chromatin pattern is open and relatively even with oval round nuclear shape and membrane, smooth membrane. And another differential is when you see HSIL is endometrial cells. See this one, very uniform. They look very histiocytic looking because they got an irregular nuclear shape. So that brings your differential to endometrial. However, HSIL tend to be flatter. They got a nuclear overlapping like this, okay? And but they're different than endometrial cells. I will show you. Those are much 3D and hardly to see any space between. Like here, you got holes in between. Usually, those are relatively round and much thicker 3D. Keratinized HSIL, occasionally seen. I would say, in my experience, less 5% among all HSILs in Pap smear. When you gonna ask us or ask age, there's no rock sense or sound criteria. But to me, these are 4 situations I call ask age. In each situation, the most important part is I don't have enough. I have a few atypical cells with high NC ratio. Then in different situations, for example, in a very young woman, less than 30-year-old, when I see this and never have HPV testing, I rather back off, ask age, get HPV tested. So she has a baseline HPV testing, and rather than I just first time call HSIL when not have enough cells, because one of the things, if clinically the biopsy is negative, they may do LEAP. That's their option in ASCCP guideline. And also, I told my cytopathology fellow, your job is to identify HSIL in the background of postmenopausal Pap smear, which is really, really difficult. Everybody know in the postmenopausal women, if you look at their Pap, it's high NC ratio with atrophy. And sometimes you have a typical, we call atypical atrophy, still in that range. So that's the very tough part. You really need experience and review the difference between HSIL in postmenopausal women or those are just atrophy. So this is a case. I have a background, a lot of L cells, and I got a few individual cells that got a higher NC ratio. Like here, you're thinking CN2 there. Individual got a higher NC, and like here. And in the past, we had a category called LSIL cannot rule out HSIL. I still love that category. Unfortunately, it's not there. Forced me to call ask age. So in the younger women, youngster, I see this. I will just push for ask age, even with few, because if I don't call ask age, this woman, even HPV positive, you call LSIL, she will not get a biopsy. So ASC guidelines just repeat path. So I would like to get this kind of, I feel higher risk. I want to dictate the course. Would like to this young lady get a biopsy. This is another case. Excuse me. You can see the background inflammation, relatively clean, and I don't have LSIL. I encounter few single individual cells here, there, and never see group. So add together maybe a dozen, less than 20 cells spread around. Here's some features with metaplastic cells, but they're really hyperchromatic, and I call ask age. And this is another one. Apparently, they look just like H cell, but I only have a few, like a dozen cells. It's a woman less than 30 years older. I call ask age. So few situations like this. I have a couple ask age in the postmenopausal. It's really hard to take a picture, and they all dark, and I just gave up. I mean, it's a good look at a scope, but not good to show in this lecture. Invasive carcinoma, you got all the features of H cell plus. Number one, most important, the striking feature is you see this dirty, inflammatory, bloody background we call tumor diaphyses. So that's a summary of that. The cancer cells are more pleomorphic than H cell. They somehow share this nuclear pleomorphism with L cell, but L cell don't have this tumor diaphyses, right? So, and you start to see prominent nucleoli. The cytoplasm often seen some kind of odd shapes I call cytoplasmic pleomorphism, tadpole, spindle, keratinized, you name it. So here's one invasive carcinoma. You can see just a low power background. You got this tumor diaphyses, very frothy background. Even in this group, you have some kind of the edge, very frothy, not a smooth round. Look at this nuclei. That's what I call the nuclear and the cytoplasmic pleomorphism, which contrasts to H cell. H cell tend to be clonal uniform. Now you got this kind of elongated, spindle, irregular, you know, the different shapes. Here you got a keratinized with the background of tumor diaphyses, you know, sickle-shaped, spindle-shaped. Look at this nuclear pleomorphism. Very large, very small, like 3 generations, which we've seen that in L cell, but L cell never have prominent nucleoli. The squamous cell carcinoma, you start to appreciate nucleation, the macronucleation. Come to glandular lesion, AIS. Highly crowded group HCG, some people use hyperchromatic, a crowded group, you know, whatever you call it, a really low power, very dark, hyper, you know, crowded group. That's what you first identify these, different than flat honeycomb benign endocervical cells. you got a nuclear overlapping. These groups tend to have a peripheral irregularity. And if you're lucky, probably in 30 to 50%, you see feathering, not every group. These reflect the polarization and wisp of cytoplasm. You got an enlarged nuclei with hyperchromasia and increased NC ratio. Mitotic figures, apoptotic bodies, you can see, but not often. So here's a histology. You got a half normal glands, and then you got a stratified, the glandular atypia, enlarged nuclei, high NC ratio, mitotic figures, and apoptosis. These are the cytology. HCG, highly crowded hyperchromatic group. And their border is started irregular. You got a really, really enlarged nuclei and irregular. You don't see that kind of, very flat, the nuclear overlapping. Another one, irregular shape, overlapping, hyperchromasia, but you don't see prominent nucleoli, and the background is relatively clean, which is separated from adenocarcinoma. So to start to see a little bit of kind of feathering, you have to use your imagination. And here they're just putting in each group is not the feathering. Most cases in my experience is not that perfect. Endometrial adenocarcinoma is not the purpose for cervical cytology, but often we see it. We see in 30 to 70% those endometrioid adenocarcinoma present in the cervical pap. They have this typical 3D ball-shaped group of atypical glandular cells with enlarged around the nuclei. Instead of hyperchromatic, their chromatin tend to be more opened and paler. They tend to have a conspicuous nucleoli with kind of vacuolar or minimal cytoplasm. The background tend to have this necrotic or old blood inflammatory background. So this is normal benign endometrial cells. You have a perfectly 3D with community border, very homogeneous small nuclei. And this is adenocarcinoma. So you got this peripherally frothy, the background and dirty, enlarged nuclei with conspicuous nucleoli and open chromatin pattern. This is another one. And when you have this one, it's a challenge. Is this endocervical or endometrial? And sometimes it's not like a textbook. Another case, a 3D, getting a little bit flatter than the normal, but enlarged nuclei associated with tumor diaphysis, 3D shape, and the borders relatively smooth compared to AIS. Endometrial serous carcinoma. Occasionally we've seen this. These are different because these are really, really high NC enlarged nuclei. What quite different, these are tend to be individual cells like necrotic bloody background. So here's a case, you have enlarged nuclei, glandular cells, you don't have much necrosis, relatively clean, they stand out. Usually you will not miss it. Another case.
I'm so sorry to interrupt you, Dr. Yang. I would just like to point out that we've got already quite a lot of questions for you. And so given that we are kind of running out of time, if it's possible for a quick wrap up in the next minute or so,
sure.
And then we'll have, we've got lots of questions.
Sure.
That's all right. Thank you so much.
Yeah, 2 to 3 minutes, I'll wrap it up. Okay, so this is a high-grade serous carcinoma. We sometimes encounter this glandular. And you can see other metastatic malignancy, not very common, but you can see it most colorectal adenocarcinoma, you can see melanoma, carcinosarcoma. I'll give you a couple cases. This is colorectal adenocarcinoma. The striking feature is a dirty background necrosis, but we see that these are different cytologically. You have a very stratified, elongated, high columnar atypical glandular cells like this, very characteristic. If you see once, you're going to think about CRC. And this is a melanoma, two different cases. One case more individually with this, and if you're not thinking about this, you're thinking this is like HSIL. They're individual high NC ratios, but their shape is quite different. They're relatively clean in the melanoma, not much necrosis. Another one, they form this syncytial group with very, very prominent nucleoli. This one, you see the biphasic pattern, you know, high-grade nuclear feature, just like a serous carcinoma. Then you have a spindle atypical cells. This one, spindle plus epithelial. This carcinosarcoma, leiomyosarcoma, just a very bizarre spindle cells with cigar-shaped nuclei. So I will stop here. I have a very cool case to show you, but I don't have much time, and I'll skip that case study. Thank you very much.
Thank you very much indeed, Professor Yang. I'm very sorry to have interrupted the talk and missing out on the case here, but we've got so many questions to get through based on what you've told us already. So the morphology is clearly, beautifully displayed and very well covered. Most of the questions seem to focus around the strategy of delivering cervical screening service with HPV testing, particularly in the setting of low and middle income countries, LMIC. And there's a sort of a theme there of questions coming from many of the attendees from different parts of the world, asking what you think is the most cost-effective way of testing in LMIC countries. And do you think vaccination over testing is on a cost-only basis?
It's a great question. I have been participate in the cervical cancer screening. We have a POI group called Preventive Oncology International under the leader, Dr. Jaron Balanson, our previous chair OBGYN. We went to China, India, Mexico, Peru, Haiti. So tend to go to these different areas. So I participate that. I was the top cytopathologist, GYN pathologist, and oversight HPV testing and quality control. So tremendous experience in that. When I went to there, for example, my hometown called Henan province in China, population is 110 million people, and roughly women and men is half-half. So if you talk about 55 million women, and say if you get an older and a younger one, you have 40 million to screen. How many? I went there, I gave many talks, because my hometown, every time I go there, I said, how many cytopathologists? These are not a cytopathology trained like our program residency. Everybody just surgical pathology and SARDA. Total together, less than 40. How can you 40 cytopathologists do 40 million women screening? It's impossible. That model from European and the US model just cannot copy to low resource area like that. So, and we did quite models. So, and we did HPV testing, different testing. And last 5 years, the HPV testing doing screening, we think that's the way. The problem 10 years ago, we cannot do it. Because the cervical cytology, say in China, charge 150 yuan to 200 yuan. But HPV testing charge 300 yuan. That cannot be doing. Till HPV testing drop. 5 years ago, we're working with one testing company in California, and we applied that over there. And also there's a home brewed HPV testing in China. do not use electricity, do not use running water, and just test. The sensitivity compromise about 7%. When you have a built lab HPV testing, that you need a setup lab, but that one is portable. Drop from 97% to like 89%, but the cost only costs $3. So instead of $55, that's tremendous. I think with this, then the California company is without just put a room temperature, they can amplify 18 HPV, $1 cost. So I think with HPV testing like that, and the price dropping, will be really important to use HPV. For example, in my hometown, identify those 10%. That's 4 million. Then those 4 million, well, you still have 40 cytopathologists. You need more cytopathologists to train, right? You probably need 100, maybe 400 cytopathology to screen that. But I think need 2 legs. We need to continuously have a cervical cytology education worldwide, not only in developing countries like England, US, or other European countries, but we need to spread this education to those countries like China, India, and other countries. So that's where I see the model going to be different. You cannot do cervical with reflex HPV in China because you just don't have manpower to do that.
Excellent. Thank you so much for your expertise and comments on there. That actually addresses many of the questions asked in one go. And there's lots of congratulations and thanks coming in to you for your presentation. There's also comments like, in view of the high spontaneous regression of low cell lesions and the poor PPV of HPV testing, don't you agree that primary screening by HPV testing is not cost effective and brings about high patient anxiety, overtreatment, and unnecessary colposcopies?
I think that's a view. I have a different view. One graduate cervical cytology, sitting in Cleveland Clinic, one of largest tertiary care. In this setting of cervical cytology, very important because you got infrastructure different. But I think a lot of questions asked that are the cytopathologist sitting like my position, never been in those rural area doing screening. When I go there after that, I view the situation is different. You just cannot do that. So HPV, so you have to think about, I'll say socioeconomic and health economic issue. For it's not individually in a hospital setting. You have to think, how can I get this big population screen in a short, high throughput way? Definitely in that setting, I'm very much against cervical cytology as forefront to do that. So I think to identify HPV infected women, then, like I said in the diagnosis, even HPV positive one, 20, among those cervical cytology negative one, normal, you have a 20% HPV positive. That should not be treated clinically. So, but if you reverse it, let's identify those 10%. Then identify, because, in the US, the big data tell you, you have 18 million HPV infected, but only 2 million got a low cell HSIL and invasive carcinoma. That's 1 out of 40 HPV infected women, right? So if you use the cytology, identify those should be, flagged for further colposcopy treatment. So I think the cervical cytology play a very important role, cannot be ignored. But I think from the epidemiology point of view, from the country, large population screening point of view, you have to think the pros and the cons.
Excellent answer. Thank you so much. So those were 2 quite sort of, pragmatic and reflective type of questions. I've got a couple of questions which might be slightly quicker ones, or not, as the case may be. So there is a question here for quality control. what should the ask to HPV ratio be? Do you have any advice?
That was a great study. I think it was more than 10 years ago that by Sibas from Harvard, Brigham woman. Ed did this great study to use HPV, and because your askers, my askers, and other person's askers is different. So how can we, in the HPV testing area, to take advantage of HPV testing? That publication is really well received. Now, our labs in past, I would say, started 8 years ago. 3 years after that publication, and we started adapt to that, and now it's become routine. So, for junior faculty, they may have a 30% among all their askers, but senior one practice, like me, been practice 30 years, my rate is going to be higher, and some are even higher. I think one of our pathologists constantly got a 60, 70. So that tell you the experience and also reflect that. I think it's good to know that, especially for cytology director, and you want to have an average. Our average is 45%, showing that we have 20 cytopathologists in our lab, but the average is just very consistent, which is great.
Lovely, thank you so much. We've still got almost 140 people online, so clearly, although we're overrunning slightly, but then we also started a little bit later. I hope you're okay for time for a couple more questions. I know we will have to draw this to a close if you've got a day's work ahead of you as well. So I think you may have already in part answered this question, but do you give a diagnosis of ASK-H with LSIL changes present, or is ASK-H sufficient?
Yeah, we use that. So Ashish, you know that, right? So before this classification, we have a maybe 5-year period of time. We use LSIL, cannot rule out HSIL, and there are quite about less than 100 publications regarding that. I think a lot of cytopathologists love it, like it, but I think a clinician hate it.
Absolutely true. Absolutely true.
Yeah, unfortunately, that category is not in our diagnosis anymore. But in those, you have to individually, like I presented that case, you have background of that. That case I presented, that was a 26-year-old. She already got a 3-year PAP, consistently asked us LSIL. Now I see, probably less than 5% of those cells higher NC. They got individualized. And so individual high NC in that background, that push me have to call ASK-H. Unfortunately, we don't use that anymore.
Absolutely. And there's also cases with differential diagnosis of atypical glandular cells and HSIL. And there's a question here asking about your experience in this regard.
Yeah, the glandular cells, so Dr. Chandra, I know this is the most challenging part in the paper.
Absolutely, yes.
Squamous has become very easy right now, especially in the HPV testing, but glandular is still very challenging. But if you look at Kaiser Permanente data, the AGC, if you call that, the HPV and follow up the rate with a significant disease, only 10%. But clinically, even that low follow up, only 10%, 90% that we call AGC are nothing or benign. Still clinically, ASCC guideline, they need to do ECC and EMC, if you call AGC not a favor cervical or things, they're going to do both. So that can tell you it's a pretty challenge. That's big data. All the AGC follow up, only 10% with disease. So I think the jury is still out. I think we cannot change the criteria. Maybe we need more study with HPV testing. I published 2013. That was AGC with HPV testing. We follow about 300,000 PAPs, and we identify all our AGC, AEC. So what we found is among those AGC, AEC, if women subsequently HPV positive, we got a 63% significant lesion. Among those, vast majority are CN2 and CN3 involved glands. Then we have 15% are true AIS. Then we have a 5% endometrial, either hyperplasia or carcinoma. So that's in HPV positive one, okay? Then we have HPV negative, we call the cytology AGC, AEC. Guess what's the percentage of significant lesion we got? 1.6%. So that tell you in the AGC glandular lesion, we cannot change our criteria, but HPV testing dramatically provide information for clinical decision.
Absolutely. Thank you. I think we're probably down to the last couple of questions now. If a woman had transient HPV infection, does this influence a future reinfection?
You know, individually, it's very hard to say because,
of course,
you know, her immune
behavior
status,
related.
Just like a catch a cold, you know, you drop immune status, you got a cold. Sometimes a virus is there. Remember this, when we testing virus, we have a threshold. Say you have RLU, that fluorescence, have to reach like 1,000. Below that, we call it negative. So even we call HPV negative, it's not really reflect this person not have HPV. So these are analytical things. We cannot be absolute, right? So I think that's very hard. And we see women got an LSIL, then regressed, then a couple years later, change your partner, got HPV again. So very hard to predict each of it individually.
Marvelous. And there's a couple of comments about, you know, the fact where people are working, they have basically stopped doing cytology completely and just switched to primary HPV testing. You know, they're sort of commenting on it and asking for your comments on this as well, about switching to primary HPV and stopping cytology altogether.
If they have a situation, they can provide a cytology. Absolutely need a cytology. Even in our clinical setting, Ashish, you probably shared a similar experience. We even cytology called Ask H, and they did a leap. There's nothing there. It's over treatment in the clinical setting. Can you imagine in the screening without cervical cytology, just HPV? You know, like we said, you know, our ASCUS rate is ASCUS rate approximately, including all the cell, is somewhere between 8 to 12%. That means among HPV infection, the women, you have a 10% cytology abnormality. These are women, you know, subject to colposcopy, which is, you know, tremendous. We serve no harm clinically. We are the gatekeeper to see, you know, stratify, triage. It's a very important part in the cervical screening whole paradigm. No, I against absolutely to drop cervical cytology.
Thank you so much.